All right, so a couple of housekeeping items real quick. First of all, how's everybody doing? Great. Awesome. Great, Grant. Awesome. Me too. Got a little more rest, so I'm a little bit more energetic today. So bear with me. I'm gonna get a little twitchy today. So as you guys know, like we're going through an upgrade with the computer systems. Whether you're aware or not, some of you got kicked off the network and all kinds of crazy stuff happened. So I went through yesterday and I updated the slide deck. Whether you guys are aware or not, this original slide deck was not mine. So I've been going through some efforts to try to make sure that I streamline things. I make it so that you guys can look at these slides and actually understand them a little bit better, right? A little bit more streamlined, a little bit easier to read. And I got that done for yesterday. But of course, like I said, we're having issues with the computer system, so I wasn't able to actually upload it, okay? But you guys will all have that at some point today. Okay, so when you go back in there and look at the slides that are in there and re-download them, it'll be all the updated stuff, okay? Make sense? I apologize for that. Like I said, I do respect your time. I do respect your efforts. I just wasn't able to overcome the hurdle. As soon as I'm done here, I'm supposed to go down and see Sergeant Spellman to get that fixed. So. Any major issues before we get started? No? Yes? It's the same ones. I just cleaned them up. Yeah, it's not like I changed anything radically. I just kind of moved things around, made it a little bit smoother to read, things like that, right? Apparently my predecessor didn't believe in spell check. I do, so that's a joke, sort of. So I cleaned things up and just made things, just flow a little bit better, right? I'm here to help you guys learn. We're all learning together, so I want to make sure again, it's more streamlined for you guys, okay? Good to go? Okay. So yesterday you guys had some questions. And like I said, if you look at it now, it looks a little bit more streamlined. You can read it a little bit easier. I did go through and, again, try to summarize things and break things down a little bit better for you guys. One thing you'll notice, too, if you go here to this slide specifically, I cleaned that up nicely, I think. So if you look at the top there, remember we were talking about the treatments? So there's the 1 and there's the 2. Why are those 1 and 2? Because they treat the underlying disease, right? And then at the bottom, I added the word adjuncts. Basically, those are things that help you treat your patient, but they don't treat the disease process itself. Does that make sense? Okay, so that's an example of how I kind of streamlined it for you guys, okay? And I am open to feedback, so if you got feedback, give it to me. Don't give it to me in an end of course, all right, because I can't change anything then. Give it to me as well, but I'm saying, if you give it to me now, I can make changes. This is another thing I added here. Very commonly in internal medicine, I would think of the word pair when it came to seronegative spondyloarthropathies. So pair is psoriatic arthritis. Enteropathic, didn't really discuss that, but enteropathic is another word for arthritis associated with irritable bowel disease. You see how I added that at the top there too? So you guys can put those two together. So enteropathic makes sense, right? Enteropathic sounds like gut stuff, right? So bowels, okay? Then the A is ankylosing spondylitis, and the R is reactive arthritis. Also known as Reiter syndrome, especially if you're an old dude like me. Reiter syndrome is kind of like falling out of favor, so it's more commonly referred to as reactive arthritis now. But if you remember this mnemonic, hopefully you guys can remember the seronegative, right? Because what is the seropositive? Rheumatoid arthritis, okay? So then you have rheumatoid arthritis in its own category, right? And then you have the other 4 in the pair. Make sense? Good to go. Okay, again, I highlighted some stuff here, some stuff I think you guys should know. Okay, just to give you guys a better sense of like when you look at a clinical vignettes, scenarios, test questions very soon, right? You're like, wait, these are the things you need to pick out of those paragraphs, right? Those sentences, right? So like, for example, ankylosing spondylitis, right? Sacroiliitis, kyphosis, more common in men. And they're HLA-B27 positive for the most part, 97%. Is that 100%? No, but that's pretty dang high, right? Make sense? So this is, again, trying to help you guys. Reactive arthritis, I highlighted that. The itis is right. This is This is usually due to some kind of GIGU, so you're going to treat the underlying disease. Okay? Psoriatic arthritis, well, that's the one with the plaques and the nail issues, things like that. I didn't really change much there. It's pretty straightforward. Did have a question about arthritis mutilans. Did you guys have a sense yesterday in your studying? Of course you went home to study, right? Of course you did. You looked at all the readings online. You went to the library and checked out the book. Yes, of course you did. But arthritis mutilans, for those of you guys who haven't had a chance yet to look it up, it's basically the short stubby fingers and the short stubby toes that can occur with psoriatic arthritis. That's a specific subset that gets that arthritis mutilans. This is not testable, but it's a low percentage. It's 5%. Okay? That's why it's thrown in there. But it's very uncommon. Okay? Short stubby toes and fingers. Still looks like psoriatic arthritis, but just very teeny-weeny toes and fingers. Okay? Good to go? Didn't throw a picture on the slide because, again, it's not testable in my opinion, but just wanted you to know what it was. There I highlighted again that the arthritis associated with the irritable bowel is also called enteropathic arthritis because that fits nicely with your mnemonic that I gave you, right? Okay? Again, try to highlight some stuff here. DIP, joint involvement. Is that present in RA? No. Okay? I can't highlight that enough. You're looking at these scenarios again throughout your career, in test taking especially. Think of it in those terms. If it says DIP involvement, it is not RA, correct?
Yes.
Good to go. Okay? Didn't change anything there. I did have a lot of questions yesterday. I had a line yesterday. Now you guys are awake. You're asking questions, right? So I had a line of questions at the end of the lecture yesterday. One of the questions was about what is this calcification, this bamboo spine, right? So the bamboo spine, I added some, I kind of like clarified it here on the right-hand side. Ankylosing spondylitis has that bamboo spine, right? So it's calcification. Basically, everything becomes mummified, if you will. But it's not eroded, right? That's how it's different. There's no erosion necessarily. It's just that the vertebrae, the intervertebral spaces, the processes, right? The spinal processes on the posterior aspect here. And we'll go through this in the anatomy next week, right? So, but the spinous processes are back here, okay? Those are all calcified. So therefore you have what that bamboo spine appearance. That's ankylosing spondylitis, okay? Now, this one on the left is not associated with ankylosing spondylitis, right? That is the pencil and cup deformity. Remember how in psoriatic arthritis there's absorption, right? That's how it's different. Well, that's what it looks like in the digits, in the toes specifically in this picture here. Everybody kind of get a concept in their mind what the pencil and cup deformity is supposed to be showing. It looks like a pointy pencil tip inside of a cup. Okay, so that's how that's different. I broke that out for you guys. That slide was very busy. Okay. Again, try to break down a little bit of the treatments so you guys can look at it a little bit better. This is a good summary if you're talking about choosing different kind of medications, how you're going to choose them based on scenarios. Okay. Question I was asked yesterday was why endomethacin? Endomethacin is the big gun NSAID, right? So endomethacin is used for a lot of different conditions. Maybe when you guys get into cardiology or talk about patent ductus arteriosus, then you get into cardiology also, you'll talk about pericarditis, things like that. But let me break it down for you guys. So if you have 600 milligrams of Motrin, that's equal to 50 milligrams of endomethacin. So what does that tell you? That tells you that endomethacin is a bigger drug, right? It's a bigger gun, okay, in your arsenal. So therefore, does it have a greater side effect profile?
Yes.
Yes, that's why we don't use it for common conditions like, for example, ooh, I stubbed my knee, or I went on a run and fell out, or something like that, twisted your knee, you know, the sprains and strains and stuff like that. We don't use endomethacin for that because it has a higher side effect profile. Okay, good to go with that? That was a really good question. Okay, and that's it. That's my summary for yesterday. What questions do you guys have from yesterday? I think if you go back and you look now at the slides, the way I've represented them, hopefully it'll flow a little bit better. Did everybody, excuse me, able to get into their minds the difference between specificity and sensitivity? Yes, I know you're smiling back there. She's like, I don't know, I think I'm there. Okay, well, let me break it down for you guys. This is orthopedics, right? I want to keep saying orthopedic surgery. This is not orthopedic surgery, this is orthopedics. Okay, so what am I going to ask you about? What is RF positive condition? Rheumatoid arthritis, right? So, which one is more sensitive or specific? Is it the ESR? Is it the CRP? What is it, right? It's the fact that they're RF positive and anti-CCP positive. So therefore, you have a higher specificity and a higher sensitivity. That's what I want you to know. Okay? There you go. I just took about 6 slides and a lot of frustration, and the lady in the back shaking her head the whole time. And hopefully summed it up for you guys. Okay? Good to go? That's what I care about. Because what are the seronegatives? Or RF negative. Okay. So we're good, right? Okay. All right. Remember, I worked in internal medicine. You want to boogie, we can boogie. But this is not that class. Good to go? All right. Let's move on to some more exciting stuff. Okay, this is actually orthopedic surgery here we're about to talk about. But compartment syndrome, okay? So what is compartment syndromes? Everybody knows that you have compartments in your body that hold things like muscles, tendons, blood vessels, and nerves, correct? Okay? Specifically, when we talk about compartment syndrome right now, excuse me, we're going to talk about increased pressure within the bounds of a compartment, right? And we're going to talk about the 4 compartments of the lower extremity. There are 4. The 4 are anterior, lateral, superficial posterior, and deep posterior. So since there are different compartments, do you think there's different muscles in those compartments? Yes. The answer is always yes, right? You guys are picking up on that, right? But I will talk to you a little bit about how to discern these things as far as what I want you to know. But just understand that you can get compartment syndrome in other places, like forearms, feet, hands, right? Okay, but the most common, for the purposes of this course at least, is the lower extremity. Okay? And then you see there in capital letters where it says acute trauma, most common, so that means acute compartment syndrome. So think of that as a subset, okay? And again, the one that's the focus of today's lecture for the most part. But then if you go down to the bottom there in capital letters, is chronic. Okay, so why do I tell that to you? Because I want you to understand that you can't have chronic be something that's a surgical emergency. Okay? When we talk about the surgical emergency, we're talking about acute. Okay, what causes it? Again, it's some form of trauma. Everybody equates trauma to, falling out of a helicopter, right? And landing on your head, for example, or something like that. But trauma can be anything that's an insult or injury to the body, okay? So don't be so narrow, tunnel vision on that. Because trauma also includes things like burns, snake bites, reperfusion syndromes, and unrelieved pressure and necrosis, okay? Make sense? Everybody thinks of trauma like one thing, but when we talk about trauma for the purposes of a lot of conditions, in medicine, it's not just the literal physical trauma. It can be insult or injury in some manner, shape, or form. Are we good with that? Okay. So what's the most common? Acute, right? So then we talk about chronic. Chronic is when you have strenuous activity over a prolonged period of time that causes the patient to experience these compressive symptoms in these compartments. Is it relieved by rest, though? Yes. That's how it's different. Acute is not relieved by rest. Okay? So there's a nice little picture there that shows the cross-section of the lower extremity. Okay? And you can see those compartments that are outlined there. And that does give you a sense of which muscles are in those compartments as well. Okay? Are we good so far? So which one do you think I'm going to test you on? Okay, moving on. So, clinical symptoms, the 6 P's: pain, pallor, paresthesias, paresis, poikilothermia. I don't know if I'm saying that right ever. Pulselessness, right? Those are the P's. What is paresis? Let's start there. What's that? Yeah, it's like you just can't use the muscle groups or anything, right? It's completely out. Is that a very serious finding? Yes, that's what you're trying to avoid getting to, because that means that there's tissue ischemia. That is what you're trying to avoid, is prolonged ischemia. Everybody knows what I mean by ischemia? Okay, prolonged ischemia that leads to damage. Make sense? Okay? Pain is most specific, and pulselessness obviously is linked, right? No pulses, bad day. Good to go? So, what is paresthesias? That's where you have that numbness and tingling. That is where they still have some sensation though, right? But they just feel numbness and tingling. Okay? What is poikilothermia? So that's that cool, clammy extremity. Okay? And obviously pallor is where you have that white, kind of pasty looking extremity. Waxy looking, right? Just devoid of blood flow. So again, those are things you're trying to avoid. Good to go? So which one do you think we are going to be testing for when we're assessing? I mean, you're going to look for all these, right? But what do you think the most important one that you're going to be looking for is? I heard them all. Okay, pain. Okay, pain, right? Right? And we'll get to that in the next slide. But just again, people look at this and they're like, wait, so one is early, one is late, one is bad. I mean, they're all bad, right? But which one are we looking for to be an assessment tool when we're evaluating the patient? And I'll talk about it here in a second, okay? Does that make sense? So chronic, again, it tells you there, no pain 30 minutes after exercise. That's rest, in parentheses, right? Is it 30 minutes exact? No, that's not an exact science, okay? But it's just saying that basically the patient's symptoms tend to resolve within 30 minutes after the cessation of whatever the activity was that caused them to have the symptoms, okay? So again, we talked about ischemia, right? So if you look on the right there, it talks about those adverse outcomes of disease. If you have ischemia, you will eventually have necrosis. Make sense? Okay? Permanent loss of function? Well, yeah, of course, right? Then you're going to have acute kidney failure. Why? What happens when all those muscle and soft tissue compression, ischemia, and all that stuff happens? One person. Rhabdomyolysis. Yeah, rhabdo, yes, okay? So you have a release of those products. They go into the bloodstream, go all over the body, and cause organ damage, correct? That was the right answer, thank you. Sorry, I can't focus on 7 people at once. I can barely focus on one person at a time. And limb loss. So if it gets bad enough, we'll start hacking limbs, okay? So this is the slide that again, you will get this, but I updated because I want you guys to understand that while you have the 6 Ps, when you call me and tell me you think you have compartment syndrome, I'm going to go down and I'm going to talk to the patient. I'm going to assess their pain level. But if somebody had trauma, do you think they're going to have pain? Yes. Yes. So pain tends to not, again, be as valuable unless it's pain out of proportion, right? It's like, oh my goodness. But I'll tell you what, if you go down and it's a lower extremity and I grab onto the toe and I flex that toe, or I plantar flex that foot and they jump off the table, that tells me something. Good to go? Okay, why do I say flexing the toe and plantar flexing the foot? Because those are the 2 things that check for anterior compartment syndrome, which is the most common, correct?
Yep.
Okay, Yes, the answer is always yes, right? So paresthesias to the first dorsal web space, sure, you can have that. Can you have that because they have an injury to a nerve as well? Yeah, you can have that, right? But again, for the purposes of what I think is important for you guys to know, you should know the 6 Ps, don't get me wrong, but when you go and you're checking these patients and the patients have pain, do they have pain out of proportion? Do they have pain with passive flexion? What is passive flexion versus active flexion? I think I heard that you're doing it and not the patient's doing it, right? That's passive, okay? Because they have active, again, look there, it says weak active dorsiflexion, possibly foot drop. That's active stuff, right? Do you think that patient's going to want to stand up and walk for you if they have acute compartment syndrome? No. This is just kind of saying, okay, these are some of the clinical symptoms that may be present. Make sense? But again, I want you guys to make sure you guys understand anterior compartment, is it in yellow? Okay, that's actually gold, but to me it looks yellow. But it's in gold, right? So the anterior compartment, that's important. Are there ways to check other compartments? Yes, there are. They're listed there. Okay? So how do you check the lateral leg? Perfect. How do you check the deep posterior? How do you check the superficial posterior? I will tell you this. Once you get to a point where you have multiple compartment syndrome, right? So you have compartment syndrome that's that extensive, you're not really going to be able to assess that. Okay? Because it's all going to hurt. If you even come near them, they're going to be in pain. Okay? Make sense? If you hit them if you stroke them with a butterfly wing, they will jump. Okay? So again, you want to prevent them from getting to that point, right? So anterior being the most common, you make sure you assess that. Okay? I added that picture there. If you look at the top right here, this is supposed to be showing you kind of a summary of that plantar flexion. Okay? That's really the only picture that makes a difference there. I shamelessly stole it from Netters. Any questions about this so far? Okay, so then we get into this. This was an area that was previously, I'm not sure what. But I will tell you this. When you're doing compartment checks, right, for acute compartment syndrome, right? Let's break it down again. We're checking for acute compartment syndrome. Do you think that if you walk down there and they have pain with passive flexion of their toe or plantar flexion of their foot, that you're going to do a needle check? No. You're just not. The diagnosis is made. You don't waste time. Somebody will hand me a scalpel, someone will hand me a betadine bottle, and I will make 2 incisions to relieve those pressures, and they will be down and dirty. Okay? Done it many times. It's not like we sit there and we measure things out and whatever. We find our general landmarks and we just start making incisions. Because guess what? Time is tissue. Correct? So the longer we wait to relieve that pressure, the more ischemia has occurred, the more the poikilothermia, right, and all those other ones, and then we get to paresis, and that's bad, right? So we don't want to get to that point. Make sense? So let's have a quick discussion about this compartment pressure checking thing. So as you guys know, I'm an exercise physiologist, right? ACSM, all that stuff. When I was in the Pacific Rim, I would commonly get called and say, hey, can you do compartment pressure checks for my patients? What kind of patients are those? Are those patients that have acute or chronic? Chronic, perfect. So, and I would say, you know what? There's got to be someone else that does this testing, right? It turned out there wasn't. I was literally the only guy in the Pacific Rim that knew how to do this because I went to school to learn how to do this on athletes, right? Guys that have chronic exertional compartment syndrome, right? So I've done a lot of these. That's what I'm trying to tell you. And I can tell you that these pressure measurements, I am not going to test you on this other than this resting 15 millimeters of mercury. Resting 15 millimeters of mercury. Okay? That's it. Because I'm telling you right now, I went to school for it, and I've tried to train physicians to do it, and it's a hands-on experience thing where you get proficiency with that. Me trying to get you guys to calculate deltas. You guys know what I mean by deltas, right? Changes in pressures. Yeah, there's no value there. Trust me. If you want to learn this stuff in the future, you guys graduate, you go out about your business, and I'm still practicing. God help us. But I'm still practicing. I'll be happy to go through it with you, okay? But I'm just telling you right now, for the purposes of chronic exertional, if they have greater than 15 million mercury delta, so change, right, increase, resting, that's clinically significant, but there's other ones as well. For example, I have somebody come in, I'll use some kind of a cleaning device, right, something betadine if that's all I have, and I'll measure the compartments. How many compartments are there? 4. I stick them 4 times with that big honking needle, right? Do I numb them up? Do I put them to sleep? No, I just go for it, right? Then I have them go run until they have symptoms. Then I have them come back. And then quickly, as they're out of breath, I re-betadine them, right? Or use a brush, right? Whatever I have. And I stick them again. Okay? Then I have them sit there and we look at each other and smile. And then about 5 minutes later, I stick them again. Okay? And then 30 minutes later, I stick them again. So what am I getting at? There's a lot there. Okay? Nobody leaves happy, trust me. Right? And I put these big bandages on and I say good luck. Right? But that's for the purposes of surgical evaluation. Okay? Now when it comes to acute compartment syndrome, that's acute treatment, right? So if you're going to stick them, right, they usually say if there's a 20 millimeters of mercury, in the anterior compartment, that's diagnostic. Okay, so it's still greater than 15, right? So what's the point I'm trying to tell you? That 15 transcends. Good to go? But what's more important, right? I had somebody call me, and hopefully this is relevant. Okay, I like to tell stories. I hope you guys appreciate it. But I got a call when I was stationed in Okinawa. I was the only orthopedic surgery PA on staff, the only one that I knew of on island. But I got a call from the ER doc. He said, hey, I got a guy, a lady, a female Marine. She's got acute compartment syndrome of her upper extremity. What did I say? That's super uncommon, right? First thing out of my mouth, I said, are you sure? And he said, yes. She's in extreme pain. I checked the P's and all this, and I'm like, do I care about all the P's? No. I care about the ones we discussed, right? And I said, all right, well, what's she like on exam? Oh, she's talking to me. She's fine. I'm like, okay. Is that how acute compartment syndrome presents? I said, what's the history of trauma? Oh, she was in a pull-up challenge. You guys work for Marines, right? So she was in a pull-up challenge 3 weeks ago. Is that acute compartment syndrome? No, okay? And I'm not using physician names. I'm not throwing anybody under the bus. But I said, all right, here's what I'm going to do. It's about 20-minute drive, right? I was like, tape a scalpel to the bed head, right, to the head of the bed, and put a betadine bottle there. Because if it's what you say, what am I going to do? I'm going to go, I'm going to release those compartments, right? So I did a quick refresher on my anatomy, because this is a common? No. But if I had to do, I had to make sure I was ready, right? I had to do it quick. So I did a quick refresher of anatomy, I drove over there. I walk in, this Marine's sitting up, she's eating a banana. Okay, she's smiling, she's talking. Yeah, she's got swelling, right? She did a lot of pull-ups, right? And she's been doing them ever since that pull-up challenge. Okay? But she had a couple of the P's. She had a little bit of paresthesias, right? Okay, she had swelling, okay? But she had no sensation otherwise. She was able to flex, extend, all the things I checked. We won't get into that because it's not testable, right? And she did not have pain with passive flexion. So I was like, we're good here. So I walked by and I said, hey, thanks for the consult, man. I'm going back home. Okay, because this always happens at what, 2 in the morning? I said, all right, I'm going back home. But you see what I'm getting at, right? The P's are there, but what is the P that tells us it's acute compartment syndrome that requires management? Pain with passive flexion, okay? So what do you think a test question might look like that I give you? I want to know, do you know how to assess this for acute compartment syndrome, right? Not just, for example, chronic or something that does not require management. Because can you have rhabdo and not have compartment syndrome?
Yeah.
Yeah, right? So that's it. Is that different treatment? Am I going to cut somebody open? No, not unless I hate them. Maybe that ER position, right? So this is some pictures of acute, right? Acute treatments, okay? I did a lot of these in Afghanistan on my first tour. Graduated PA school civilian, right? Prior military, but came on active duty, said you're deploying with Marines. You're going to a forward deployed shock trauma platoon. I said, gulp. I am a primary care guy. My program was literally primary care, okay? I haven't done any kind of trauma stuff in quite some time. I did a lot of these, okay? Because we had IED blast, all that stuff. I was RC Southwest, Afghanistan. I'm sure you guys, some of you guys have been there. We were getting combat replacements within weeks, days, okay? It was highly kinetic. So if we had to relieve, I was 45 kilometers from the border of Pakistan. It was an hour flight to Bagram. Do you think we have to relieve the pressures before they get to Bagram?
Yeah.
Yes. Bastion was about 42 mics away-ish by helicopter, if they could come in, right? Troops in combat, troops in context, using all that stuff going on. So we did a lot of these, okay? Will you guys be doing these? Maybe. You never know where you're going to end up, okay? But I will tell you this, if you think it's compartment syndrome, you need to do something. Find somebody, okay? Find the general surgeon. They're probably asleep somewhere, all right? Find them, okay? But do something about it. Because you did your pain with passive stretch, right? And they have it present, or the trauma is significant. Good to go? So then we talk about chronic. Is the treatment the same? Well, yes, it's the same, but it's done a little bit cleaner, right? It's done under general anesthesia, for example. Okay? It's done planned. We measure our landmarks. We get MRIs, right? We do things like that. Okay? So it's a little bit more measured. Okay? But is it without consequence? No. Make incisions. Okay? Do they heal?
Yes.
Eventually, but you'd be surprised the number of wound complications we get from those incisions that we make. There are a couple of different techniques. We won't get into surgical stuff. But even if you do the minimal techniques, you know, sometimes you have a significant issue with people healing, okay? Does everybody return to full duty after releases for chronic exertional compartment syndrome? The answer is no. This is where the answer is actually no. Sorry. All right, so they don't. So it's not 100%, okay, guys? And sometimes you don't get a complete release, right? You go in there and you think you released everything. You guys are used to the fact that I cuss a little bit every once in a while, right? So we stick our fingers into those wounds after we make the incisions and run our instruments up and down and try to make sure we break everything up, but sometimes we get an incomplete release, so then you have to go back, right? So then guess what? You cut through those incisions again, and then you watch them heal again forever. Okay, so giant scars. Wound healing complications. Okay? Referral decisions, find somebody. You think you got a acute compartment syndrome, find somebody. If it's chronic, work them up. Okay? Do you think that some people that get chronic exertional compartment syndrome symptoms can improve with physical therapy? Yeah, you would hope so, right? Because the surgical options are not the best. Okay? I have a serious discussion with people. Remember I told you I did all the testing. So I'd have a discussion with a person and say, hey, just so you know, the reason I'm doing this test is to see if you meet operative criteria. This is not to diagnose you. Do you want surgery if you have operative criteria? And if they say no, I void the test. I'm like, I don't want to do this test on them. Just let me know. Make sense? So make sure as primary care people that you work them up. Do they have flat feet? Do they have tight calves? Do they run weird? Okay? Don't watch them run. I'm not saying that. but maybe there's something that physical therapy can look at and say, hey, we can improve this, and maybe their symptoms improve. Make sense? Don't just send everybody to orthopedics, please. Because guess what I'm going to do? Send them to physical therapy. Send them to watch people run, have them be watched running weird. All those things, okay? Make sense? Okay. And then if they circle back, excuse me, if they circle back, we'll get some imaging, and then maybe they'll get the testing, if they consent to the testing. Does this sound like a pleasurable experience to get that test done?
No.
Heck no. Do I like doing them? You guys will think I'm weird, but it's not the worst thing. Okay? So questions about compartment syndrome. Do you think you're going to hear compartment syndrome in my course, in emergency medicine, in surgery? We call it surgery, which is general surgery here. Yes, you're going to hear about this again and again and again. So make sure you get these principles down, okay? Learn the 6 Ps, learn what the ones are that are early, that are late, and never, ever, ever forget the fact that pain with passive stretch, right? Passive flexion, okay? Because you're stretching the muscles in the anterior compartment when you flex the toe and you plantar flex the foot, okay? Those are the ones that are the most sensitive for intervention. Good to go? Okay, out of curiosity, has anybody seen a compartment release before? You have? Okay, so you know that, sometimes you just got to go for it, right? You probably got a little baggie, you got some fentanyl lollipops, you got all kinds of stuff, right? So you try to make them comfortable, but trust me, unless they're completely out, it's going to suck. Okay? All right, that's it for that topic. No questions about it? Okay, so this is the topic, complete complex regional pain syndrome. Man, when you guys start dealing with this in primary care in your practice, you are going to hate this topic. But you need to know how to recognize this topic because it's so multifactorial that you need to understand when it's present, okay? And we'll get into it. Complex regional pain syndrome. I think it's better described as reflex sympathetic dystrophy, okay? And so does your textbook, by the way, because it really tells you what's going on there, okay? There's some kind of dystrophy, right? There's some kind of dysmorphic relationship with the patient's condition, okay? And we'll get into that. Hopefully that'll make sense here in a second. But it's a clinical diagnosis of pain, altered sensation, circulatory disturbances, trophic changes, and functional impairment. So it's a constellation of things, okay? Sometimes people say, well, it's like a diagnosis of exclusion, right? Because you're making sure nothing else is going on, and then you're left with what? CRIPS, complex regional pain syndrome, okay? What is oligodystrophy? It's on the screen. Burning pain, okay? So that's like a burning pain, meaning that's a pain that they describe to you as a burning pain, right? So that is kind of a pathognomonic, if you will, if you're given a scenario like on pants. Okay, how is that different? Let's go ahead and slow down a little bit to speed up, right? How is that different than compartment syndrome? Is there a history of acute trauma? No. Okay, so there we go. So there are 2 different kinds. Type 1, no identifiable nerve injury. Notice we're talking about nerves, right? That's that sympathetic portion of the dystrophy, okay? What is type 2? A nerve lesion exists. So on and off, basically. Type 1, there's nerve involvement. Type 2, there's no nerve involvement. Good to go? Okay. Rare condition, yes, unless you're treating certain populations and then you see it a lot. But the key factors here, and I'm not getting on any one group of people, but women, smokers, 30 to 50 years old. Okay? Does smoking have a high incidence with CRIPS? Yes. So you'll hear it now, you'll hear it in the future if you're in my clinical group. I'm sorry. But I will tell you all the time, hey, did you ask them if this patient smokes? Right? Because when it comes to orthopedic conditions, we want to know that. Okay? Does smoking inhibit healing?
Yes.
Does smoking cause peripheral sensation changes that are intermittent sometimes?
Yes.
Does smoking cause intermittent discoloration of the fingertips and lower extremities.
Yes.
Okay, so you get some of that with this. That's why it kind of gets tied in here, okay? Good to go? All right, so nerve pain. When you think about nerve pain, you guys go out there to phase 2 and you're rotating out there, right? And the doc asks you, you say, well, you think this patient has Crips, what makes you think? And you say, well, they have nerve pain. Okay, nerve pain is nerve pain, but it's specifically burning, tearing, searing, or throbbing pain. The word hallmark is in parentheses and it's all in gold, right? So do you think a PANS question, again, will look like that?
Sure.
Yes. Okay, and there'll probably be some component of an injury, but not acute, right? Not acute injury. And there'll be some level of discoloration or vascular changes. Good to go? Okay. What is allodynia? Okay. We're going to look that up. Someone's going to tell me what allodynia is by the end of the session today. Okay. Because it's important to understand that. What's hyperpathia? That one's in parentheses, so you can just read that one, right? Right. So it extends beyond the normal nerve distribution. So what? Yes.
Answer your question. It's pain from a non-painful stimulus.
Okay. So pain out of proportion, or pain that just doesn't make sense. Thank you very much. Yes. He's just trying to be Mr. Smart Guy. Thank you. Hyperesthesia. What's hyperesthesia? Yeah, so basically, again, it doesn't make sense, right? I'll walk up to this gentleman here. What's your last name, sir? Gregory? Okay. I'll walk up to him, and I just lightly stroke, right? Appropriately. His lateral forearm, right? His lateral forearm, and he, as soon as I touch him, he's like screaming. He's like, oh my God, that hurts so much. That's hyperesthesia, okay? So, do you think, and again, I'm not judging, right? Not a little bit. But do you think that there's certain patient populations out there that are a little bit more prone to say, ooh, that really hurts, and you're like, really? Like, really? Right? The pain scale doesn't apply to them, right? They don't understand what it is. What's your pain on a scale of 1 to 10? They say 50. You're like, again, I said 1 out of 10, right? 11. They just won't stop, right? So, but this hyperesthesia, again, goes together with the other symptoms. It's not just that they only have hyperesthesia. Good to go? Okay. Man, you guys are more awake today. That's awesome. So vasomotor changes, that's that changing of the colors, right? Discoloration. Okay? So you see that limb there? It's kind of red, flushed. Okay? Do you think that might come and go? Yeah, it might come and go. It might not always be like that. Okay? But that's that cyanosis, mottling, flushing, increase or decrease in skin temperature, right? Pseudomotor changes, edema, abnormally moist or dry skin. Now we'll talk a little bit in a few classes about claudication. So just, again, I'll try to break it down and tell you how it's different than that. But you guys have talked about claudication so far, right? Yeah, in some class, pathology probably, I think. Yeah, okay. So just understand that this goes associated again. Motor or trophic changes. Trophic changes specifically refers to what? Atrophies, right? Changes in tone, okay? If you see a change in the tone, so you look at one palm versus the other, everybody knows what the thenar region is? Yes, north and south, okay. So therefore you have a hypothenar region, right? So you look at one side, right, and it looks a little bit decreased bulk compared to the unaffected side. Okay, so you look at the affected side, and you have changes, right? Those trophic changes. Make sense? Okay. Unexplained weakness, tremor, muscle atrophy, stiff joints, thin skin, changes in nails, hair texture, and osteoporosis. Okay, that's all thrown in there. But I just gave you a really good example of what you're probably going to see. Because is the patient, if they have hyperesthesia and all that, allodynia and all those other symptoms, do you think they're using the extremity like normal? Good. Okay, good to go. That's a funky looking leg. Okay, but that's actually a really good picture that shows that flushing, right? That change. Okay. So, what is it about, I'm going to go to that real quick, but let's go back real quick. So when we go back here and we talk about complex regional pain syndrome, and you talk about these symptoms here, okay, the hypersthesis and stuff like that. I was making a joke earlier, but a lot of times it can be some association with behavioral health issues. Okay, just the perception of pain that the patient may have, and they maybe have other conditions that are skewing their view of things. Does that make sense? Okay, so just make sure you're assessing that, okay? Because if you do have, say somebody had a fall a couple weeks ago, right, sustained an injury, and now they come to you and they say they're having this pain on compulsion, these vascular changes, these trophic changes, excuse me, and you're like, okay, well, I think you have Crips, but then you realize, hey, I think you also got more going on here. Some maybe behavioral health issues that need to be addressed. I think that's what we're calling it now, behavioral life sciences or something. All right, so you need to address those things as well. Life skills, right? Don't forget that stuff. Make sense? But the medication treatment for it is gabapentin. Okay? Remember we talked about this as nerve pain? Okay? Remember that? Type 1 is nerve pain. Okay? So if they're having nerve pain, you got to use a medication to treat nerve pain. Did you guys cover gabapentin yet? Okay, so we're good. I like that. Okay, so basically gabapentin or pregabalin, right? There's other ones too. I just want you to know what class. Okay? Am I going to ask you dosages, routes? I mean, obviously it's going to be oral, right? But no, I'm not going to ask you dosages, but I want you to make sure you understand, like if you're talking about nerve pain, you're going to treat it. Right? What are some of the other names? Neurontin, Lyrica, things like that, right? Do those have side effect profiles that can affect mental health issues? They do. Do they cause sedation? They do. So don't just use them lightly. Make sure you look it up if you haven't used it in a while, or if you just want to make sure you're using the dosage appropriate to the patient and their chemistry experiment that they got going on with their other medications. Okay, good to go? Physical occupational therapy, what can they do? Is it a strength issue? No. But occupational therapy, especially for upper extremities, can do some desensitization. Yes, sir. So basically they do things for that hyperesthesia, right? To try to get them to have less of that hypersensation, if you will, of pain, okay? Nerve pain, right? And they can also give them things like stockings, okay, to cover the area, right? So that if they just lightly brush on something, they might not have that issue, right? Like if Gregory had a glove on, right, and I came over and I appropriately, again, stroked his lateral forearm, right? Would he feel it as much as if he had something over that covering it? No, right? So they have things like that they use as well. Okay, and they also have other treatments that they are really good at. Psych, counseling, right? So parentheses, coping and biofeedback. What's biofeedback? Yeah, just different techniques to try to have the patient have some kind of coping mechanisms, right? Some coping strategies, if you will. Okay, we won't go too far into that. Blocks for intrathecal pump for pain. Okay, so what is a block? So a block can be a regional block, right? You literally block the sensation that is being experienced to that particular region of the body, and therefore they have less of that pain sensation, right? They're not registering that pain like they normally would. Make sense? Intrathecal pumps, this is actually pretty cool stuff. So when I worked for the chief of sports medicine for the Air Force Academy, right? So they started doing this little balloon, we called it, or pump, right? So they would insert a catheter into the upper scaling region, and this was an indwelling catheter. It stays there, and it periodically pumps an anesthetic into that region to have that regional anesthesia that keeps going and going and going. This is after the surgery. Okay, we did shoulder surgery. Okay, we did general anesthesia, but then they also had this pump placed to manage their post-operative pain. Make sense? So, obviously it's not something you're going to see very commonly, but when you start operating in the civilian sector, because the academy operating room is closed, all kinds of stuff starts getting paid for, right? But I will tell you that it's very effective. So you may see that as a treatment modality that's chosen for patients with Crips. Good to go? Okay. I'll put you guys on break here in a second. Bear with me. Success is based on the timeliness of diagnosis and treatment. This is what I'll tell you guys need to be good at. When you guys are in primary care, right? Question? Oh, I'm sorry. Did I have a question? I was like, I haven't even finished my sentence yet. But so you guys are in primary care, you need to be able to sniff this stuff out and figure out, does this patient have Crips? Do you think, and you know the answer is yes, right? But do you think that if you start gabapentin or pregabalin sooner, that the efficacy of treatment will be greater? Your success rate, yes, you will. So again, you need to be good at this, okay? Sniff it out, okay? If a patient has a history of an injury, what are you going to get? X-rays. Yes, okay, you're going to get X-rays. You don't see anything, right? Are you going to do a neurological assessment? Yes. And you have findings, okay? Are you going to do a behavioral health screening?
Yes.
Yes. So then you put it all together, right? You decide, do I think this patient has Crips? If you send them to me, all right, with speech surgery, because they have upper extremity, like Mr. Gregory, right? He has upper extremity. Hyperesthesia, he has penile proportion, he has intermittent discoloration, but I don't see anything that's operative. What do you think I'm going to do with him? Send him back to you. But I will start him on pregabalin, because I know that's time sensitive thing, right? How long does it take to get in to see me in Misawa? About 6 weeks, okay? So I'm going to start him on the meds, because time is not tissue in this case, but it's important. Okay, make sense? Okay. Good to go. All right, let's break. Come back. I'll keep it coming. Okay, want to make sure we're all getting it. I told you guys I eliminated the quizzes, but I will do spot checks. Sometimes I'll do pulse checks just to make sure you're still alive. So that's why I put you on break. So I might have misspoke. Thank you for pointing that out. Type 1. Right? So type 1 is no identifiable nerve injury. Type 2, a nerve lesion exists. Okay? So if I misspoke previous session, I apologize. Okay? Do we think in those terms in orthopedics?
No.
Heck no. Like, we just don't. But this is the textbook stuff that it's important for you guys to understand and successfully navigate IPAP. Okay? Good to go? Okay. So another question that was asked, because you guys are all becoming astute clinicians, right? Is there a history of trauma? Yes. 50%, some studies say upwards of 70%, believe it or not, have a history of preceding trauma. But is it acute trauma? That's what differentiates it from compartment syndrome, right? And most other conditions. Okay? Good to go? So they may have a history of fractures. They may have a history of a fall. The reason I say trauma is because remember I expanded the definition of trauma earlier, and I said it's injury or insult to a body part. Is the brain a body part? It is. That's why the 70% exists. And it went up 20% when they started including behavioral health stuff, mental health. Okay? Because is that trauma? Yes, mental trauma is trauma. Good to go? Okay. All right. Any other questions about that stuff? Burning, searing pain. What are you thinking about? Crips, right? Complex regional pain syndrome. Think if you're sitting there in a test, right? You're either looking up at the sky for the answer or looking down, right? Choosing the answer, right? Think about what the words mean. Okay? I've been trying to break down these orthopedic words for you guys so you never really have to memorize them per se. You can literally take the word and say, what does it mean? Complex, meaning a lot going on. Regional, meaning a body part. Pain, meaning there's pain. What kind of pain? Burning, searing, okay? And syndrome, meaning there could be a lot of symptoms present. So therefore, what is your treatment options going to be? Multifactorial, right? Yeah, so if you're going to treat the pain, neurologic pain, is the gabapentin going to do anything for their behavioral health issues? No. Okay, so just think about it like that, okay? I'm trying to give you guys a study technique, okay? Crystalline, notice how I say crystalline, right? Crystalline. Deposition disease. You guys talked about this a little bit in pathology, right? And clinical core? Oh, clean lab, okay, good, awesome. Okay, so this is going to be not really a review, hopefully a review to some extent, but again, further defining it in terms of how I think it's important for this course, okay? So what is gout? Okay. What kind of crystals? Monosodium urate crystals, right? Okay. So then, if that is that, there's another one called pseudogout. So what is that? And there's a lot of chat. All right. So calcium pyrophosphate is, I think I heard somewhere. Okay. Make sense? Deposition disease. Okay. So, but they're both deposition diseases, right? Probably what you guys said is right, but I just didn't get catch all. But just understand that's what it is. Okay. So what's going to be important for a person in this course is that I'm going to ask you what those crystals are. Okay, and we'll talk about that here in a second. Okay. But in gout, and I know I'm going to get a million questions, right? But in gout, you can have under excretors of uric acid and over producers of uric acid. Okay? Am I going to ask you the pathophysiology of the renal aspects of gout? No, this is orthopedics. But I always get asked a question, so I'll tell you. Under excretors means there's some kind of issue getting rid of it, right? So therefore, because of these kind of renal tubular issues, yes. So there you go. Over producers, well, that's literally what it sounds like. Okay, so you're making too much, and there's not enough receptors to uptake it all. Okay? That's it. That's for the purpose of my course, just to make sure I'm clear. Anything that you guys want to add to that you guys have learned that you may be able to educate me on? No? Nobody wants to show up the instructor, right? Not yet. So these crystals, they get deposited in what? Okay, so that's why it's an ortho. Good to go? Okay, so gout. If you think of gout, think of toe. Specifically, which toe? The great toe, the hallux. Okay? All right? So, if you think about pseudogout, think of, it's on the screen. Knees. Okay? Pseudogout, very common in knees. Okay? Can you have gout in toes and knees?
Yes.
Yes, but we'll talk about how things are different. But I would tell you this, if you're taking a PANCE exam, you will probably get that 46-year-old Asian American descent male, or Polynesian descent male, with a poor diet, type 2 diabetes, and, you guys are high-fiving back there, let me know later. So, and they have a red swollen toe. Text me when you get that question, okay? Because I'm telling you, you're going to see it eventually, right? And they're going to want to know, what is this? What are you going to think immediately? Gout, right? Okay. So here's some awesome little pictures. I didn't put those on there, but there's some awesome little pictures, you know, to liven things up a little bit. But I will tell you with gout, what we talk about is that it's episodic. Okay? Can pseudogout be episodic too? Yes. Okay? So again, we haven't really gotten anywhere if we're just saying episodic. But with gout, podagra is 50% of initial episodes. 50%. That's a large amount, right? What's podagra? It's a big toe thing, right? The hallux. Okay? Good to go? So there you go. Followed by knee, ankle, tarsal joint. The number one thing that it can be confused with is septic. Okay? Septic arthritis. So arthritis, again, meaning that it is inflammation of the joint, right? But septic meaning that it's infectious in nature. So now we've introduced another type of arthritis, right? Uric acid levels often low in acute events. Okay? So you're going to think to yourself, well, why wouldn't it be high in acute events? Because it's sitting in the, yes, it's the flare-up. Because when they say uric acid levels, are they talking about the levels in the joint? Serum, thank you. Okay, so there you go. I will clarify that for the future because I think that is something that needs to be clarified on the slide, in case people don't get it as I'm lecturing. But I think it's important for you to know that, and you guys are right on it. Okay, there's a difference between levels when it comes to serum levels and when it comes to intra-articular aspirations. Okay, I'm introducing that concept now. I know you guys know what it is, but because we're going to talk about septic arthritis in a little bit. Pseudo-gout needs 50%. 50% needs in pseudo-gout. So you think it might be a clinical scenario you get that ends up being pseudo-gout? Maybe confused with RA. Okay, rheumatoid arthritis. And we'll talk about that here in a little bit. But gout can obviously cause bad things in bad places. So the kidneys take a hit a lot of times, okay? Especially if there's some of that dysregulation going on with the uric acid. Renal stones, can you get stones that are specific to gout? Yes. And what do you think they're going to find when they take that pebble out of the nurse's hat, right? When the patient passes it after excruciating pain, and they take that little stone and they send it to the lab, and they break it down. What's going to be in it?
Uric crystals?
Yeah, monosodium urate. Okay, good. Perfect. Okay. Due to hyperuricemia. Okay, there we go. So on physical exam, the one on the left is the toe, right? The top right, bottom right, those are tophi. That is where you've had that prolonged deposition, and now it is present at all times. So if you see a picture like that, does that look like a nodule of RA? No, it doesn't, right? It looks different. It looks kind of chunky. It's almost like cottage cheese looks like it's trying to burst out of those things, right? It doesn't look like those non-tender nodules, subcutaneous nodules that we talked about in RA. And is it found in the elbows? Oh, the plantar surfaces? Fingertips, toes, maybe? Yeah. Okay. All right. That's why it's different. Okay. So let me just be clear. It is not found in the tips of the elbow, right? And on the plantar aspects. Okay. You're trying to convince me it is, but it's not. Yeah. Everybody clear on that aspect? Okay. So you're going to get X-rays, of course. Okay. Why do we get X-rays with gout? Because we see things in gout that are pathognomonic for gout, especially when we make the diagnosis of gout. Okay? In gout, start thinking about these things. Highlight these things, okay? Gout has subchondral erosions. Subchondral erosions, very specific. It's not like RA. This is why sometimes it's confused with RA. The crystalline deposition diseases are confused because they do have erosions. But the difference is there's periarticular spurs. Okay? Can you guys appreciate that from these pictures? No? Yeah. Yes? Okay. Periarticular spurs, meaning on the edges of the articular surfaces, there's little finger projections. Can you see them now? In that top left picture there? Okay. So if you come up to this picture here, you see those little spurs that are coming out the edges of the bone, the little finger projections. If you squint really hard, you still don't see them? Okay. I'll try to find some better pictures for you guys. But you do appreciate the subchondral erosions though, right? Yeah, okay, you do appreciate that. So right there and right there, it's eroded, okay? So, subchondral, yes sir? Mm-hmm. It is, it still is. Yeah, so the rat bite thing, that's a pathognomonic, or kind of a buzzword, if you will, for the erosions in gout. And so it looks like a rat literally went to those articular edges and chewed them up, right? So that's kind of a buzzword way of thinking of that. So, thank you. right? But that's a subchondral cystic changes, okay? We talk about the subchondral erosions. Okay, it looks like a rat went in there and chewed it out. Good to go? Okay? I don't really like to use rat bite. We don't really use those terminologies in ortho. So, yeah, we don't talk like that, it's weird. So, yeah, we also don't use terms like Colley's fracture, Smith, I forgot what that was when I graduated fellowship. Right, and we'll get into that. You'll be like, this guy's weird. But we don't talk that way because we describe the fracture. We describe the pathology. What I see there are subchondral erosions and periarticular spurs. There seems to be a narrowing of the joint spaces. There's malalignment at the PIP joints. That's how I talk. I don't say, oh, I see red light lesions. Right? Makes sense? There's nothing wrong with that, though. Yeah, there's nothing wrong with it. He's like, you're telling me. No, I'm not. I'm just telling you, these things are really good to know, though, because, well, how is the pants going to test you? Potentially, like that. Right? They're going to ask you Smith fracture, Colley's fractures. They're going to ask you red light lesions. What's that? Oh, they will. Okay. Yeah, no, they will. Yeah, so thank you for bringing that up. And now that I've berated them, we'll move on. So pseudo-gout, thank you for throwing that in there. Chondrocalcinosis. Okay, this is how pseudo-gout is different. Okay, if you remember nothing else from this slide, remember a lot, but if you remember nothing else about pseudo-gout, remember meniscus. Okay? Because what happens is that you get a calcified appearance of the menisci. Are you supposed to be able to see a meniscus on a radiograph? Because it's soft tissue, right? So if it becomes calcified, then you see this. See the two freaking arrows? Yeah, you see those two arrows right there? You can see that meniscus in there now. It's been calcified. Right? Calcinosis. That's like calcinosis, like chondrocalcinosis. Chondro meaning cartilage. Is a meniscus made of cartilage? Okay, so we got there. Make sense? Okay, so that's that chondrocalcinosis. Can it be the TFCC as well, the triangular fibrocartilage complex?
Yeah.
Everybody point to where that is found. Okay, that is found on the ulnar, not the medial, right? We talked about this yesterday. The ulnar aspect, distal aspect of your wrist. Make sense? Right there. That soft spot you're pushing into right there. Okay, it's also called a phobia test. Okay, when you're pushing right there and the patient has pain right there, you're pushing on the TFCC. That's called a phobia test. Is that testable? No, but you're welcome. Okay, so, but anyways, it can be found there too. Do you think that's going to be harder to see though? Yes, right? So I would tell you that I don't think that would be a fair test question, but chondrocalcinosis of the menisci, and you're given a clinical scenario that asks you to differentiate between gout and pseudo-gout, which are you going to choose? Perfect. So this is where we get into the lab testing, okay? So negatively birefringent needle-like crystals. What do you think I'm going to tell you they're ureate crystals? Maybe. I'm not that mean, okay? But I'm just saying, if you see those negatively refringent needle-like, that's that top purple. I don't know, I'm a little colorblind maybe, so it's the top picture. Okay, top picture up here, see those little needles? Okay, that is gout. Pseudo-gout, then the bottom one, right? What I think is pink, but it's not needle-like, okay? And they're positively birefringent, rhomboid-shaped crystals. Okay, do they have to be predominantly rhomboid? No, but every so many per microscopic field will be rhomboid in appearance. Okay, you guys know that I have a background in microbiology as well. So I have literally drawn the fluid from someone's knee and taken it down to the lab myself as an orthopedic surgery PA, and they're always very confused. They're like, what's this guy doing? And I'm like, you guys are taking too long. I can do this test. Why is it called birefringent? Because there's a spectrometry that occurs, right? Okay, so it's not just a regular microscope. Okay, there's some tricks that are done too. But that's an examination of what? Synovial fluid, right? So how do we get that synovial fluid out? Aspirations, perfect. Do we still get inflammatory markers?
Yes.
Yes. Are they specific or sensitive for gout or versus pseudo-gout? No, they suck, right? They don't really tell you much. Okay? Do we still get a CBC? Yes. We talked about it earlier that it might not necessarily show anything though, right? Is gout, pseudo-gout infection? No. So it may, again, not really help you much, but we get it just to rule out things like septic arthritis. Okay? Going back to that aspiration, do we only look at the slide? No. We also run other tests on the fluid as well. Okay? Does that make sense? So that's that gram stain and that's that culture. What's the gram stain for? You're trying to see bugs. What's the culture for? You're trying to grow bugs. Make sense? Okay. Can somebody have a concomitant infection with a history of gout? Yes, that's the worst patient ever, right? Because you're like, I know you have gout, but I think you also have septic arthritis. That's a bad day. You know, I'm sitting down in the lab, literally like, dude, can you run my labs already so I can take this guy to the operating room and do the Lord's work, right? Because what are we gonna have to do if it is infection? Wash it out. Because what's the concept? Time is tissue. What tissue specifically? The cartilage. Yes. Yes, we're learning. This is great. I love it. Okay, so see, crystalline deposition disease. Okay, this is a nice little. I actually do like this slide, right? Because this slide right here, it breaks it down a lot better, and it really zeroes in on the difference between gout and pseudo-gout. Yeah, I wasn't going to give it to you right away. I had to make it work for it. All right? But I think it's important to understand, because I literally just gave you an insight into how I'm going to test you on this. Okay? So, treatment for gout. What was the drug we mentioned yesterday? Indomethacin, the big gun, right? If you use Motrin, do you think it's going to work quick? No. No, don't worry, they'll come back. Yeah, we don't want patients coming back. Treat them and treat them. Colchicine is specific. Okay, I'm not going to go into pharmacology again, but I will tell you that again, the NSAIDs, specifically the indomethacin and the colchicine are the acute treatments. Okay, and then we talked about the overproducers and their secretors, right? Do we want to prevent them from having another flare?
Yes.
Yes. So then you start selecting drugs like probenecide, allopurinol, depending on what type of patient they are. You start doing other blood work, right? Do you think that blood work you do on the acute basis can help you decide that?
Yeah.
No, it won't. You have to get them out of the acute phase, right? Have them follow up, okay? And then you do baseline labs and see where they're at. Make sense? And what else is important? I told you, and again, this is not against anybody. I spent a lot of time in Guam, Pacific Rim, right? But if you're let's say Filipino descent, and you eat a lot of pork, and you drink a lot of alcohol, sounds like me, then you're of certain ethnicities and heritage, you're more predisposed to this, okay? So therefore you have to take that into account. We're the party poopers when it comes to people that like to live their lifestyle and they have gout, okay? Pseudo-gout is, do we use indomethacin for pseudo-gout? Yes, we can, absolutely, 100%. But is it inside the joint as far as some kind of osis, right? It's inflammation. So if they're having acute inflammation, do you think that we might do steroid injections as well?
Yeah.
Yes. Are we going to go in there and remove their meniscus? Not unless we want to replace it, right? You still need it, right? But if it's painful, we might do something and then have to do a replacement. But you're going to have to do some kind of temporizing measure, okay? So the logical question becomes dabble astute. So do we never do steroid injections for gout? I'm not saying that, okay? I will tell you this. If you have an angry digit, like, take one of those, right? Say that toe is like 5 times the size of that. Big, red, angry, beefy. Do you think you're going to be able to put steroids into that joint when it's that inflamed? Heck no. So you're going to have to aspirate it first and then put the steroids in. Does that make sense? So that might not necessarily be a first-line treatment. Good to go? Okay. I get called all the time to do that. They're like, hey, what's your thoughts on doing steroid injections on people with acute gouty flare-ups? I'm like, I'm sorry, bad connection. What? I still can't hear you. I'm sorry, you're gonna have to call me back. Because I'm like, oh my God. Because then you gotta deal with the patient's pain too, right? Do you think sticking a needle into a small joint like their toe is gonna hurt if they're having an acute gouty flare?
Yeah.
Heck yeah. So what my lesson to you guys is, well, I shouldn't say call Ortho, but call somebody who knows how to do as well, because you want to do it one time. You know, not the pin cushion technique. Okay, good to go. All right, DVT, deep vein thrombosis. We should be able to get to this quick because you guys have covered this many times. Okay, deep vein thrombosis. What's Burkhardt triad? Anybody call it out? Okay, mumble. I think I heard venous stasis, internal damage to the vein, so intimal damage, right? And a hypercoagulability. Okay, that's how I remember it. Do you think in some way, shape, or form, Pace is going to ask you a question that pertains to this?
Yeah.
3,005,000,000%. Okay? Text me when you get that question. All right? Because I promise you. But when it relates to orthopedics, do we do surgery on people's lower extremities and then put them in casts and tell them to be non-weight bearing? Yes. Does that? So you're saying no to me? Okay. I do, I promise. Yeah, we do all the time. Okay. So, so when you do that, right, it puts them at a higher risk, right? What other things put them at risk? Not really the purpose of this course, but smoking, right? We hate smokers. We hate it. Oral contraceptives, right? Things like that. Okay. Look at the whole picture. Look at the whole patient. Well, when it relates to surgery, patient, you get a history during an OSCE, right? And the patient says, I had an appendectomy. Okay? Or I had orthopedic surgery. What's the next logical question? When? Yes. How long ago? Exactly. If it's within the preceding 2 weeks, is there a risk of a DVT high?
Yes.
Yes. That's it. And so a DVT can lead to a pulmonary embolism. Is the DVT the beginning, or is the DVT automatically a pulmonary embolism? It's the beginning, right? So DVT, PE, it's like a spectrum, right? You go from one end to the other. Not everybody with a DVT will get a PE. That's what I'm trying to say. Okay? Unrecognized in 2/3 of the cases when it pertains specifically to surgery, we probably missed it a lot. Because we're just like, I don't know, they have calf pain, you know, we did operate on their Achilles tendon, right? They have a little redness there, but we made a huge walk-in incision on the posterior aspect there, about 4 centimeters, and we went down there and grabbed both ends of the Achilles tendon and chopped them up a little bit, sewed them together, right? Then we did this big bundle of knot, and then we closed everything up, and then we put them into a big bulky splint. So then when we take it off a week later, do you think it looks red and kind of angry-ish? Yeah, right? So that's what I'm saying. We probably miss a couple of DVTs here and there. But what makes it different, right? Swollen pain with swollen limb with severe pain. So remember I talked to you guys about that pain on proportion? Okay? Can you get compartment syndrome if that swelling is significant enough?
Yes.
100%. Okay? Unexplained fever or leukocytosis. What is leukocytosis? Is leukocytosis something you draw from their blood or from their joint? Blood, right? That's how this one's different. Good to go? Okay? And then if you progress in that spectrum and that clot, which is normally in the lower aspect, right? Lower aspect, progresses and moves, it goes where? To the pulmonary artery. Arterioles, smaller blood vessels. So that's why it's called pulmonary embolism, right? So then they have shortness of breath, right? So what is the triad that you guys learned about DVTs? Shortness of breath, chest pain, tachycardia, okay? All right? So you guys are thinking about these things when you're talking about OSCEs, right? Right? Do you think you might be given a patient that has a surgical history and then they go on to have a DVT? Yes. So then you look at your vital signs, right? I stopped walking for a second for effect. So you look at your vital signs and you see that they're tachycardic and they're tachypneic and they have a little bit of an elevated temperature and they had a preceding surgery a week ago. and they have they complain of lower extremity pain, right? What are you ruling out? DVT progression to PE, right? Make sense? Don't be like, oh, I'm doing an ortho exam. Yeah, sure, do an ortho exam if you want, but don't miss the other stuff, because then you cause harm, right? Or death. So this is orthopedic specific, Holman's test. So you basically take, some people do this differently, but what we teach here is that you take the extremity and you put it in extension. So what does that mean? That means you don't have the knee flexed, okay? You have the knee in full extension, right? Because you put the most tension on the posterior aspect, and then you passively or actively stretch. Passively, right? Passively dorsiflex, which puts a stretch on the posterior aspect. Make sense? And so then if the patient reports pain, right, then you have a positive Holman's sign. Okay? Sometimes called a Holman's test. I'm not that particular about these kind of things. So, imaging, not really a purpose of orthopedics, but it is important to understand that if you're going to do imaging, there's this new technology now. We've always done ultrasounds, right? Because that's what we do, to look for those DVTs down low. Okay? But now they're doing compressive ultrasounds. What I will tell you is read what it says there, right? Bedside, non-invasive procedure, but then also read what it says there at the bottom. Observer dependent. That means operator dependent. That means it's only as good as the person's proficiency that's doing the test. Is it going to be you doing it? Maybe. All right. Somebody said yes. Find me later. Yeah, but no, I'm joking. But what I'm trying to get at is if you're trained on it and you're good at it, okay, then okay, cool. But what is the gold standard? Okay. What would you guys learn in your courses before? CT, pulmonary angiography. Okay, that's still the currently most validated test. Okay, makes sense? So what do you think I'm going to test you on? CT, pulmonary angiogram. Okay, angiography. Angiogram, angiography, same thing. Okay, good to go? Just understand that you guys get out there in clinic and someone says, hey, I know how to do these. And you're like, oh, yeah, cool. Watch them do it if you don't trust them. See if they seem like they know what they're doing. You guys can recognize that going down this branch is supposed to keep going down, right? Right? So there's double arrow. So this is supposed to keep going down. They're supposed to be. Okay? They don't. Okay? Questions about that?
Just to clarify, when you suspect PE was CTA, but just for DVT also, you can't do the
This is ultrasound, so that's looking for the DVT, right? But if you're thinking of PE, then it's going to be the CT angiogram.
The contrast to see it, not radiograph.
Yeah, that's what that's showing there. On the left there, you saw my this.
CTA.
Yeah, that's a CTA. Yeah, absolutely. Yeah, that's what that's showing right there. Okay? This picture on the right is an ultrasound, okay? Alright? But don't worry about that one. Can you guys see the compression there where that arrow is? If the arrow wasn't there? Would you know what that is? No. Would I know what that is? No. What do I do if I order, because we order a lot of ultrasounds in the ortho, a lot. Because do we send everybody to CT? No? Do you have to do pulmonary angiography? No, you can do venous angiography as well. You can do angiography of extremities, right? Okay? Everybody get that? Am I confusing anybody yet? I'll keep trying. But what I'm getting at is that the ultrasound, can we get those quick? Yes. Are they non-invasive? Yes. Do they put any kind of contrast load on the kidneys?
No.
No. Okay, so we do a lot of ultrasounds. And then if we suspect that they have a pulmonary embolism, then we'll send them for CT pulmonary angiogram. Make sense? Yeah. But do we ever send them for CT pulmonary angiogram if we don't suspect they have tachycardia, tachypnea, things like that?
No.
No. Okay. Did I clarify that, sir? Okay. That's a good question. Okay. Because people get confused because they're like, well, now in ortho it says we're supposed to do this thing. We're just looking for the lower extremity DVT evaluation. We're not looking for the pulmonary embolism. Make sense? That's how we're different orthopedics. If there's a PE, do you think they come to us? I don't care if I do the surgery or not. Like, they don't come to me, they go to vascular. They get admitted to internal medicine, for example. Like real medicine people, not ortho. We kill people. Yeah, we're good at surgery, we suck at medicine, right? A little bit of a joke there. PAs tend to be better because we're awesome. But, and this stopped working. Let's figure out what's going on here. But those are all really good questions. There we go. Okay? So, give me a pop-up and it still doesn't want to go. Okay, I guess we'll do this. So when we're talking about DVTs, what do we do in surgery, in orthopedics, to prevent them from getting a DVT? So we can do medications, right? We can do compressive stockings, right? We can do intermittent compression, right? And that's what that device is there on the bottom right. You see that device there that's attached to the leg and the foot? So the left foot and the right leg, right? So those periodically will squeeze and basically encourage or create venous return. Make sense? So you don't have venous stasis. Isn't that one of Burkhoff's triads? You don't want that stasis, right? Okay. So what are some of the things that we do? Specifically, we do like polytrauma or like total joints, right? Then we put them on mechanical prophylaxis. Okay. You can also use medications like heparin, enoxaparin, warfarin, and aspirin. Aspirin is very commonly used for sports medicine cases, and the enoxaparin, Lovenox, is more commonly used for people with more significant comorbidities. Okay? But I will tell you this, just understand that you need to consider starting prophylaxis, right, DVT prophylaxis, on patients that you know are going to have prolonged immobilization. Is that good? So you guys do understand that, you know, I just want you to have a general sense that the medications are out there. I'm not going to ask you dosages, okay? Can you give enoxaparin by injection, subcutaneous injections? Some people know, yes, you can, right? Do you give warfarin by injection? No, you don't. I'm not going to ask you questions like that, though, okay? Just do a little research. You guys will learn about them in pharmacology. Just understand what goes with what, okay? Good? Aspirin, very inexpensive, very cheap, very easy to use. Problem with aspirin is, can you turn it off right away? No. Can you turn warfarin off right away? Yes. You can give things, okay? I worked in hematology oncology for one of the biggest practices in the country. You're like, Dallas, you're crazy, right? So, but I'm just telling you, we had a Coumadin, warfarin, right? Clinic. People would come in all the time, bleeding like crazy. Then we get a little paper cut and they just wouldn't stop bleeding. We could give them something to get them to stop bleeding, right? Can you do that with aspirin? No. So the reason I tell you that is just make sure that you know what treatment's appropriate for your type of patient. If they have a history of a bleeding disorder, are you going to give them aspirin? Not unless you want to watch them bleed out. I mean, you know, so just be careful. So treatment, I already mentioned this. Treatment, if they do have a PE especially, is vascular, not ortho. Good to go? Okay. So this is what we talked about today. Okay? Rheumatoid arthritis, a form of arthritis, but, well, it's what we talked about in this lecture series, I should say. Rheumatoid arthritis is a type of arthritis, right? Arthritis is not arthritis. Understand how rheumatoid arthritis is different than osteoarthritis, please, and thank you. Seronegative spondyloarthropathies, what's the pair? Psoriatic arthritis, enteropathic, I threw that one at you, good job. Ankylosing spondylitis, and reactive arthritis, otherwise previously known, as writers. Okay? Compartment syndrome. Acute compartment syndrome is a surgical emergency. If you miss it, tissue will die, potentially the patient will die too. Don't be that provider, please. Okay? When we talk about complex regional pain syndrome, think about what the term is, and it's also called regional, what's the other term? The dystrophy? Sympathetic dystrophy, okay? Just think about the term that, hey, look for the cause. If you find no specific cause for them to be having this level of symptoms, you probably have Crips. I hate to teach you that way, but trust me, when you are sitting in clinic 2 years from now and you're like, man, I think I got Crips, you're like, Davos was right. Because you look everywhere and you find nothing, right? Because you can do nerve conduction studies and it's all normal. You're like, why is this patient having these issues? It's not a conduction issue, it's a sensation issue. Make sense? So you can have a bunch of negative testing, right? But look for the causes and don't forget about the behavioral health factors involved with that. Crystalline deposition disease, we talked about gout versus pseudo-gout, right? Understand those different, if I was to give you a scenario that tells you like positively biofringent, negatively biofringent, rhomboid, needle-like, right? Okay? And then do not fall into the trap of misreading the question, and the question tells you, not just for my test, by the way, for PANCE, to me that's more important. I know you gotta survive my test to get there, but I'm saying, don't fall for the trap of not reading the question and understanding what is elevated. Is it the serum, or is it the fluid that was taken from the knee tap, for example, right? Understand what the fluid is. What are the lab values that you're being given? Okay, for PANCE, if you haven't heard this already, you will get reference ranges, okay? You will. You guys know that? Okay. I don't know those reference ranges, right? I have to look that stuff up too. So, right? So you will get reference ranges, but you still have to know, is it fluid that was taken by an aspiration, or is it serum fluid? Okay? Make sense? When you guys do a check for chlamydia, do you do a DNA probe? Yeah, gem probe, right? Okay, so you understand that's a send out, right? You don't get a lab test right away. The result right away, right? That's a send out in some places. Okay, so understand what I'm getting at is understand what the test is that you order. Okay, make sense? Or what the fluid analysis is that you're looking at, or whatever it is lab related that you're looking at. Okay, did I get that example yet? All right, and then DVT. Understand that DVT and PE is a spectrum. Okay, choose the appropriate eval based on where the patient sits in that spectrum. If it's early on, you got a positive Pullman's, but they got no pulmonary symptoms. How do I say your last name, sir? Represent. Okay, represent. So if it's early on and you're just trying to find the clot in the lower extremity, you'll do a compressive ultrasound. If they have tachycardia, tachypnea, right, and elevated temperature, not fever necessarily, it's just elevated, right? It doesn't have to be a fever, right? Then you're doing a CT pulmonary angiography. But that's still the gold standard. Okay? Good to go? That's all I got. Well, do you guys have any questions for me before I break you guys? Okay, thank you.